title of this talk is Needle Insertion and Injection Skills. And I think while regional anesthesia previously has been called an art, and ultrasound without doubt has made this art more accessible to ordinary people like myself, it's still a technical procedure that requires expertise. And I think it's quite evident to all of us that that amount of expertise will determine the efficacy of your block as well as the safety. We've all seen pneumothoraces described, intraneural injections described, intravascular injections described, and I would argue that these are all the results of improperly placed or improperly localized needle tips, and hence should be entirely avoidable. And it's my hope to, again, share with you some pearls that will help you achieve this. So it should be easy in theory. Ultrasound allows us to see our target, it allows us to see our needle, and we should be able to put the two together quite safely and accurately. But as any of us who've picked up a probe and a needle know, it's not actually easy in practice. And the first problem arises from the fact that needles are actually very hard to see in ultrasound. Most of the standard block needles behave as specular reflectors, and so the ultrasound waves reflect away from the probe rather than back to it. And in 2007, Thomas Grau and his colleagues demonstrated this when they tested all the available block needles and found that none of them was optimal, and certainly at angles more than 45 degrees, very, very few of them produce an acceptable image. We're not even talking about a good image, an acceptable image. The second problem with seeing needles is that you have to align them with the beam, and that in itself is challenging. There are two common approaches that the needle takes to the beam, either in the plane of the beam or perpendicular to the plane or out of plane to the beam. And if you think about it, the outer diameter of our standard 22-gauge block needle is only 0.7 millimeters. The width of a typical ultrasound beam, depending whether you're talking about linear or curved array, anywhere from 1 to 3 millimeters. And so you're trying to line up these two structures that are millimeters wide in diameter, and you can imagine then how difficult that's going to be. The third problem is that we are doing this block while looking away and off at a screen and not down our hands, and yet performing these very complex bimanual manipulations. The other thing is that, as the previous speakers have alluded to, we're getting our information from a two-dimensional image, but we're moving things in 3 dimensions. Add it all up and you can see again why this is very, very challenging. So let's look at some ways at which we can help to address these problems. Let's start first with when we're doing our pre-scanning and we're getting ready to insert the needle. It's very, very important that you pay attention to ergonomics. If you don't, you're going to find that you're not comfortable. You're going to find that your ability to manipulate your hands while looking off at the screen is going to be impaired. You're going to get tired, and all those things are going to affect your manual dexterity. What do we mean by good ergonomics? Correct bed height. And by correct bed height, it usually means that you should be standing upright, your shoulders and elbows down by your sides in a relaxed position, and have the machine positioned in such a way that you can see it while standing square to the patient and your probe and needle. If you're twisted or rotated, you will find that unconsciously your body will want to move back to that neutral position, and that can throw your needle and probe off in relationship to one another. So remember to stand square. Finally, you want to hold the transducer appropriately. And this is, I always think about it as teaching a novice how to do laryngoscopy. Inevitably, when they first pick it up, they have the laryngoscope unbalanced. They're using all their wrong muscles, too many muscles, too much strength. Their hands start to shiver and shake within a minute. And yet we all learn eventually to perform laryngoscopy with a controlled and relaxed arm. It's the same with the transducer. You want to be able to control that probe, but with minimum effort. And what that usually entails is holding the probe low down, again, shoulder and elbow in a comfortable position, and you really want to brace your hand on the patient's body. And this is because we usually apply a liberal amount of gel to the skin, and if you don't do that, you're going to find that you're slipping all over the place, and you won't be able to keep your probe in one position. So remember those. The second thing is, again, going back to the fact that we are looking at and intervening on 3-dimensional structures. So although we're getting these 2-dimensional images, you want to train yourself to think in 3 dimensions and create mental images of what you're seeing. So as you're scanning, you're getting a picture and building in your mind's eye what the nerve and its surrounding tissues look like under the skin over a certain distance. The third dimension that you're creating for yourself is generated by the transducer movement. So you have your picture now. You think you know where the nerve is lying. Where do we actually put the needle? Let's start with the in-plane approach. The considerations are, what is the angle of trajectory that you want to insert your needle at? And the shallower the trajectory, the better your needle will be seen, and vice versa. The trade-off of a shallow trajectory is you may have a longer needle path to the target, which may need a longer needle, and or may cause a little bit more discomfort to the patient. The depth of your target is going to influence what you choose to some extent as well. So looking here at the left-hand image, for most superficial nerves, it's appropriate to insert your needle at the edge of the probe, and most of the times your angle of insertion is not going to exceed 45 degrees, which should give you a good image of your needle in most circumstances. However, if you're talking about something deeper, and you use the same strategy inserting it right next to your probe, you're going to find that you have a very steep needle trajectory, and it's going to be very hard to see your needle. In such circumstances, one other option may be to insert it a distance away from the probe. And in this case, you want to see your needle before it goes anywhere. So move your probe towards your needle. Forget about seeing your target for now. Find your needle tip. And then, once you found it, follow your needle as it advances towards the target and slide it back. This is a fairly common mistake among novices, and I just want to highlight it to you. It's this pinning of the skin due to the fact that when you press down, you may indent the skin as you see here, and without knowing it, you'll pass your needle through and through 2 layers of epidermis. This is not only painful for the patient, and this is one of the telltale signs if they complain of a lot of pain, you should think about this. But what happens is that later on when you're trying to alter the trajectory of the needle, you're going to find that it's very, very difficult because your needle is fixed in 2 places. There's an easy solution to this, and that is as you're inserting your needle, look down at the probe, take your eyes off the screen, concentrate on putting that needle in. Just like when you do a video laryngoscope, we look at how we're putting the scope into the mouth before we turn our attention to that video screen. Once our needle is in the tissues, we now need to find it on its way in towards the target. It's very important to grasp the various probe movements that you can make. They're summarized by the mnemonic part. P being pressure, very, very important for optimizing image quality, but it also helps to minimize the slippage that can occur in the gel. The most basic movement is a sliding movement, also known as alignment, because it is the primary movement that you would make to align your beam and needle. You can also rotate the probe, and you can tilt the probe. But when we're talking about attaining alignment, as I've said before, sliding should really be the primary movement, and this is because you can make the smallest adjustments in beam position relative to the needle. You should resort to tilting only if you're unable to slide. For example, in the supraclavicular block, when the clavicle stops us from directing the beam any more chordate, we then have to tilt. But remember that as you tilt, the lateral distance that's traversed by the beam is going to vary depending on the depth of the target which you're interested in. So be very, very careful about the degrees of tilt that you put into your probe. Rotation is a movement mainly used to align the shaft and your tip, but note that this is often not necessary. I have to say that most of the time, my needle is always slightly tangential to the beam. It's very, very hard to keep it completely in line all the time. The most important thing is that the tip and the distal portion of the needle should be the ones in plane with the beam. So unless it's grossly rotated and grossly tangential, I don't worry too much about making big rotatory movements. Really, hand movements can be summed up as needing to be smooth, small, and controlled. And if you're trying to find a needle, it's best to move just one of the two, either your probe or your needle, and not both. In general, we do say not to move your needle, or certainly not to advance it if it's not visible. Rather, you should move the probe and try and find your needle. This little clip here of a supraclavicular block, I just want to illustrate to you sort of the degrees of movement that we would make on the probe. So watch my hands and the magnitude of movements that I'm making. And note too that I'm having to tilt a little bit because I am up against the clavicle. And then you're going to see the corresponding pictures on ultrasound. You see I get a very good picture of my needle, but it flickers in and out. And those small little movements that you saw just now make the difference between seeing the needle clearly or not seeing it at all. The thing I want to say, though, is that it is quite normal for that visibility to vary almost sort of second to second, and you almost have to continually make movements in order to keep it in view, and that's perfectly fine. The other tip is, as you're putting in and you want to find the tip, always keep the bevel of the needle facing up, because that gives the tip a characteristic double echo, which helps to identify it. Here you see a needle coming in over the axillary artery. We see the needle where it appears to end, and one could easily think that that was going to be the tip. And in fact, it could be the tip if the bevel wasn't facing up. But if you have your bevel facing up, what you're going to realize is that this is an example of being tangential to your beam, and you're just seeing the shaft where it cuts the beam. If your bevel is up, you will know that you have to adjust your probe, either rotate or slide it a little bit more, and then bring your tip into view. So you're unlikely to advance too far thinking your needle's only here when in fact it's all the way over there. And it isn't always possible to see the needle. I've actually stopped nagging trainees to say, show me the needle, because I realize a lot of the time when I'm doing a block, my needle is not perfectly visible. The difference, though, is between knowing where your needle is at all times versus being able to see it clearly. And you can know where it is without seeing it. The key is really tissue motion, and I'm going to illustrate that to you with this short little clip of an infraclavicular block. Our needle is going to be coming in. This is the lateral cord. We're trying to get to the lateral cord, and you'll see that we never really see the needle clearly throughout this clip. Yet, I would argue that at all times you can see quite definitely by the tissue movement where that tip is. You can see it going through the pec minor and now just indenting on top of that fascia overlying the lateral cord. So the take-home message from that is that movement is easy to see in ultrasound, even if the needle is not. And so indirect cues become very, very important when you're trying to localize your needle tip. The first movement that is most commonly taught is jiggling the needle in and out. And this illustrates it here. These small jiggling movements, I must tell you, do not equate to advancing the needle. You're just generating a little bit of tissue motion with a blunt block needle. They're not actually going to injure any tissue or penetrate anything. The problem with jiggling is that it generates tissue motion that's transmitted beyond the tip of the needle. The one that I find more useful is this one here, seesawing or levering the needle. I'm just going to play the clip again, but essentially you move your hub through a small arc, and the tip and the tissues at the tip will move through a similar arc. And anything beyond the tip does not move at all. So I find this the most useful maneuver in the in-plane approach for localizing a tip. The other thing is that you can feel your way as you advance your needle. We've all got experience of this with our spinals and epidurals. We're feeling the flavum, we're feeling the difference between muscle, feeling the difference between ligaments. Same thing here, except now you can correlate that feel with what you see on the screen. In this particular example, we're doing what we call a transversalis fascia plane block. The aim is to get below the fascia of transversus abdominis and inject at this point. And you'll see here that, again, I don't see the needle well because it's deep, it's steep, but I know that I've penetrated the fascia because I tented it. There was a pop, and the tissues all relaxed back, which told me that I had penetrated that layer, and thus I was below it and where I needed to be. Finally, that injection that you saw, hydrolocation, that's our final confirmation that we're actually in the right place, and that's where we should be delivering our local anesthetic. Hydrolocation really, to me, is the injection of a very small amount of local anesthetic, which is important for two reasons. Number one, if it's intravascular, 1/2 to 1 ml of local anesthetic isn't really going to cause any harm. If you're in a nerve, well, the current evidence would suggest that most of the time it's fairly safe too. So inject 1/2 to 1 milliliter of fluid each time to confirm where you are. And in this image of a musculocutaneous nerve, again, We're trying to get into that compartment around the nerve. We don't see the needle at all. But the pattern of spread of our little aliquots of fluid, and I'll tell you that that amount of spread is generated only by a mil of fluid, is your confirmation that your needle is in the right place and the nerve is not injured here. If you are grossly misaligned, though, you could miss, and especially with deep blocks, you could miss the appearance of fluid. So try and make sure that you have a reasonably good image of your tip before you actually inject that 0.5 to 1 mil of fluid. Let's look now at the out-of-plane approach, which is, to my mind, a technique that requires slightly different skills and principles. So once again, going back to needle insertion, where do you insert the needle relative to the probe in the out-of-plane approach? They both have the tip and the shaft have very similar appearances, and it's important to be able to distinguish the two. If you choose to insert the needle at a relatively shallow angle and far away from the probe, the problem is that you could scan for quite a distance along the needle shaft before you actually find the tip, and you're thus increasing the risk that you're going to mistake the two. If the target is deep enough, what I tend to suggest in most out-of-plane blocks is that you insert close to the probe and at quite a steep angle, because this limits the amount of travel that you have to make in order to trace shaft and find your tip. This does not hold, however, if you're doing something very superficial, because what will happen is if you do that, you might actually reach your target before you actually come into the plane of the beam. The deep perineal nerve and in the ankle block is one good example of this. For these shallow structures, you really want to be at a more shallow angle and perhaps a little bit further away from your probe. So, to summarize, try and differentiate the shaft from the tip. There's sometimes an acoustic shadow that you'll see, and look for that. And think about a steeper angle of insertion close to the probe for deep targets, but remember to go shallow if it's very, very superficial. Localizing the needle tip during advancement. Remember that in this, the probe has to be moved to track the needle tip. The other thing is that tip visualization in out-of-plane approach is difficult but not always necessary. The indirect cues in the out-of-plane approach are extremely important. Again, we have needle motion, and there are two movements that we're going to make, what I call the up and down jiggle, and the other one is a side-to-side waggle. Tactile and visual props and hydrolocation. So let's illustrate this jiggling and waggling. This is in a phantom model. So as I'm coming in, you can actually see my tip already. I've maintained good alignment here, but can you see how the jiggling works to locate your tip? And if you're bouncing up and down top of a fascial structure, it shows you where you are. But this waggle, you can actually indent and make a fascia move up and down. In this clip, you notice now when I do the waggle, the whole fascia is moving with me instead of indenting up and down. And by scanning a little bit, you'll see now that actually my needle has traversed that fascia rather than being on top of it. So that's a giveaway sign that the needle tip's deeper than you think it is. Visual pops are very important. This is an image of the femoral nerve. You will see here that we're coming down next to the femoral nerve. Hydrolocation has shown us an inappropriate pattern of spread. It's spreading between two fascial planes rather than around the nerve. So we're going to push in a little bit more. And again, you saw that pop, that indenting and relaxation. That tells us we've penetrated the next fascial layer, and now as we inject, we see local spreading quite nicely around the femoral nerve in its compartment. Finally, I want to move on to what we call appropriate and inappropriate injections and delivery of local anesthetic. And perhaps want to address one of the questions that was brought at the last session about how you get through the fascial sheath of a nerve without necessarily penetrating it. I was very, very glad to have what I've been practicing vindicated by authorities like Carlo Franco and Bernard Margel. My observation has been that there is always a fascial or cleavage plane around all nerves, and what you want to do is enter that fascia and not the nerve. The way to do this without puncturing the nerve is always to approach the nerve obliquely, and in fact this applies to vessels as well. If you want to get past a vessel and not puncture it, make sure you're coming in at a tangent to it, and both nerves and vessels will roll away from our blunt needle tip. This illustrates to you the rolling of the nerve. Here we are tenting the fascia around the infraclavicular plexus, the lateral cord, and you can see as we're coming in obliquely and tenting, the lateral cord's moving itself out of the way, and if I push through, my needle will skim past the lateral cord and not into it. This musculocutaneous nerve shows you too. And also appreciate how much force it takes to penetrate that fascia. Here we are pushing through that fascia between coracobrachialis and biceps. And inevitably, you will go through and through. And that's why it's very important to approach obliquely through the nerve. You want to make sure that if you did go through and through, you're not going to go into the nerve. And then, knowing that you've gone through and through, you want to be pulling back, doing little bits of hydrolocation to get yourself in the right plane. So once we've popped through here again, you'll see that the first injection is going to be just in the muscle here. Pull back a little bit, inject another little bit, and you'll see then that we enter the right compartment. This is an illustration of the popliteal nerve in the mid-thigh, and again, this addresses directly that question that was raised. I don't come in at 12 o'clock to the nerve. If I do that, the force required to pop through that fascia will take me straight into the nerve. Instead, what you want to do, what you want to do is actually to go down to the side of the nerve. And you can see coming in at 1 o'clock to the nerve here, I'm pushing through and popping through. And with my needle in here, because of that cleavage plane, as I inject around it, the local will spread from here right around the nerve. So you do not have to be directly over the nerve to achieve a good injection pattern. I'm going to go on to address the question of, is circumferential spread necessary around a nerve? Now, there are actually two studies that have looked at this. Both of them have been in the sciatic, popliteal sciatic region. So first of all, Morale, they did a neurostimulation guided block and assessed the results of that after the fact with ultrasound. And what they found was that if a circumferential pattern was achieved, they had a faster onset of block, and perhaps you could argue a greater efficacy of block, 91% versus 85% of complete sensory block. My colleague Ricky did a similar study. This time they used ultrasound to guide their block, but they performed a single injection at 12 o'clock. They didn't reposition in one group. In the other group, they repositioned if necessary to try and get a circumferential spread. And once again, when there was circumferential spread, there certainly was a faster onset of a block, and one could argue perhaps a higher rate of efficacy. I would argue that try and achieve circumferential spread only if the act of repositioning a needle can be done safely, and certainly don't inject huge amounts of local just to try and get that lagoon sign or donut sign. Sometimes the local spreads up and down the nerve as well, and if you scan up and down along the nerve, you'll see that it's tending to spread up and down rather than around. I would also argue that it's unnecessary for small nerves. The sciatic popliteal nerve has a lot of connective tissue. You may need a lot more local to diffuse through, but for small nerves like the musculocutaneous and the other peripheral nerves or the upper limb, it's unnecessary. If you did want to achieve it, this is how I usually do it. My initial insertion is tangential again, 7 or 8 o'clock to the nerve. That usually results in a U-shaped spread. And then I just walk the needle up to about 10 or 11 o'clock and inject there, and it usually spreads around the other side. Similarly, with the outer plane, same thing. Attack the 10 or 11 o'clock position, get spread around one hemisphere, and then switch over to the 1 or 2 o'clock and you get spread around the other hemisphere. This is an illustration of that principle in a common peroneal nerve that I just did this week. Here's a nerve we're injecting. We're just pierced the sheath. Again, you saw that relaxation. And as we inject here at the 3 or 4 o'clock position, you'll see how it's tending to dissect around the lower edge of the common peroneal. And then as I go up above it and inject at the 1 or 2 o'clock position, you'll see how the spread tends to go this way around. And you can move your needle safely through that lake of local anesthetic to further reposition it if necessary.